do, ways that you treat people?
Yeah. So I practice, I would think similar to how you do as well, diversified. So I kind of use a multiple approach. I do a lot of soft tissue work, so a lot of muscle work.
Yep.
And train in ART, active release. I saw you talking to Will about that. And, it's a great system. That's all I'll go into on it. I use a lot of what they teach, quite a bit. So every
Gotcha.
patient has some form of soft tissue work.
Yep.
An ART type movement of some sort. I think soft tissue work is so important. So I incorporate that with everybody.
Yeah, I'm going to expand on that just for a second.
Yeah,
So,
okay.
yeah, I do. We treat very similarly, which is why I wanted to bring you on.
Of
But
course.
for me, it's like there's three things that stand out to me. One is soft tissue, because muscles attach to bones. So if there's an issue with the movement, you're not gonna fix it by just strictly treating the joint. You have to treat what's around the joint, which includes the soft tissue. So
Absolutely.
there's a reason why there's a limitation in range of motion, or there's pain with a particular movement. So you have to address the muscles. And a good way to do that is through soft tissue. And one of the techniques being ART or using instruments or whatever it is. But you have to address the soft tissue some way. In my practice, if a massage therapist wants to do that piece, by all means, do it. But as long as the patient gets it, as long as they receive that treatment, that's what I care about. Secondarily, like some sort of movement, mobilization or manipulation to the joint. So it might be an adjustment, or it might be actually just moving the knee through ranges of motion over and over, just to kind of get it used to what a normal movement pattern is. And then the last piece is exercise. You have to teach them so that they can implement it themselves. And I think that's key, because if they're not doing it, their brain's not using that muscle or firing up that pattern consistently, which is why it's falling apart or why it's causing pain. That's the main reason. That's what I tell people. I am doing this soft tissue, and I'm not just strictly adjusting. You know, I can adjust it, but if one side is tighter than the other, there's an imbalance. And it's always going to go back to where it was, which is why you can get adjusted multiple times in a day, and you feel that relief for 20, 30 minutes or an hour or 2 hours, and then go back to where it was, because soft tissue needs to be addressed for sure.
Yeah, so I usually start with soft tissue of some sort, and then like there's much more to do. So mobilization, manipulation, get the joints moving the way you want them to and the way they should.
What are your thoughts on? I attended a seminar at CMCC, and one of the docs was the sports chiropractor for Team Canada's, like I think it was Taekwondo or karate or something like that for the Olympics. And what he was saying was try to adjust it first and then do the soft tissue, because if you adjust it and it kind of, let's say, reduces the pain immediately, then maybe you don't have to do the soft tissue. What are your thoughts?
Yeah, very valid approach too.
Yeah.
And that's the thing with our profession. There's so many different ways to go about it.
Yeah.
I think, I mean, for some reason, I tend to do my soft tissue first.
Yeah, me too. In my mind, it's just like you can loosen up the soft tissue. It'll just make the adjustment go much easier than you're fighting, tight muscles or whatever it is. That's just my philosophy. But it's like, in his case, like he's dealing with Taekwondo where people are at a high performance level. And if they get injured, you have 30 seconds to help them in a timeout and then put them back out there. You don't have time to go through ART and all that. So you might as well adjust them. So maybe that's his philosophy, but that makes sense.
Yeah, and it might work for his patient base. Or he's found the way he does it, he gets good results, which is awesome.
Right.
I'm kind of the same wavelength as you, where I don't want to adjust through, a muscular tension or make it uncomfortable. So, and also I don't want to adjust if I don't need to adjust.
Correct.
So if I can get things moving better and loosened up, and movement patterns are kind of where I want them to be without adjustment, that's fine. I'm okay with that.
So how many people do you end up adjusting? Or percentage-wise, let's say.
Percentage-wise, I'd probably say maybe 75% of my patients get adjusted.
Okay.
Just whether it's an adjustment or mobilization or something like that. So I'd say majority.
Yeah. Yeah, I'm probably at about 40 or 50%. Not that high.
Yeah.
It's just some people are just weary about it, so it's like I just don't even want to open that Pandora's box. So I just leave it. I'm just like, hey, listen, like we're gonna try it this way. If it doesn't work, then adjustment might be what you need. Well, maybe we'll try that in a few visits once you're a little bit more comfortable, because trust is a big thing with adjustments as well.
Yeah, and that, I mean, I'll have patients who I'll adjust them one time I see them, the next time we're not. And it varies visit to visit. So from there, then after my adjustments, it's usually some kind of rehab. But I also will incorporate acupuncture in, or dry needling,
Yeah.
electro. So I kind of approach that in the same way I do soft tissue work, where I'll do terms acupuncture, dry needling, intramuscular stimulation. You hear all those. Really, it's all the same. It just depends on your approach. So I call it acupuncture because that's what my diploma calls it, medical acupuncture. But it incorporates what you would typically see someone who does dry needling into it as well. So what it is, I don't follow meridians or energy chi, things like that. A lot of the points I'll use are anatomically based. So if someone's coming in for, say, a shoulder injury or whatever, I'm going to look at the muscles that are affecting the shoulder joint that seem to be overactive or lazy, or lack of a better term, inhibited, and
Yeah.
I'll put the needles into the muscles I want to affect one way or the other,
Gotcha.
whether it be directly in the shoulder or something a little bit further away that's affecting the shoulder. So I'm not doing, say, a shoulder injury comes in, I'm not doing head to toe acupuncture or needling. I'm
Yeah.
doing local in the shoulder, anatomically based. I have a reason for where I'm putting the needles based on the structures that are there and their function.
Yeah.
I might spread out a little bit from that to surrounding areas that are affecting it, but it's more of a local anatomically based approach.
Gotcha. Okay.
And I use stimulation with that, so kind of an electric stim
Yeah.
to get muscle twitches, kind of activate muscles, inhibit, get movement patterns I want as well.
Yeah.
So yeah, it varies again patient to patient, but it's definitely not a traditional approach. This is kind of an approach that you see more often now. Again, evidence informed.
Right.
So even though some of the points may have a traditional name,
Yeah.
they might be in the same location. I'm hitting this point because, well, your infraspinatus is there. It's not, I can't remember even the name, small intestine 11 or whatever it is. I don't know. I forgot those because it's
Yeah.
not how.
It's like people ask me about acupuncture all the time. They're like, hey, listen, like, I'm having low back pain. Do you think acupuncture will help? I'd be like, my rule is go out and try it. If it helps you, great. If it doesn't, that's not for you. Also, that's one practitioner. You could go to a different practitioner who treats slightly differently, and they're going to
Yeah,
have a different feel and touch to it. So I never say no. And I also tell them, like, listen, I don't know enough about this. It's not my
right,
field, but I do know that it is beneficial, which is why it's still out there and running and exists, and insurance is paying for it. That's a big thing for me. I think if
right.
insurance is covering it, it means it works to some extent.
Yeah,
Um, and if insurance isn't covering it, maybe it doesn't have enough research behind it yet. That's also a possibility, right? So my
yeah,
rule behind new treatments and new things is always to go out and try it. And there's different ways that different people do things, right? So my approach of biomechanically looking at someone and then treating those muscles. So let's say for you, you might be doing acupuncture to the quads or whatever it is. Maybe that didn't work. Maybe
right,
when you go to a traditional acupuncturist, maybe when they do it, they might be not targeting that quad. Maybe they might be putting in your foot or something like that, and all of a sudden the pain goes away. Great,
right.
that's what you need. So maybe you should
Work,
try a
right?
different approach. And I like that mindset that it's just a different way of thinking about the body, because I
Yeah,
appreciate that more, because the medical way is more like the knee hurts, let's look at the knee, everything around the knee, let's look at the way that works. For us, it's like, let's look at a slightly bigger picture. How's that whole leg moving? How's the ankle moving? How's the
yeah,
hip moving? How are they running, squatting, things like that. For traditional Chinese acupuncture, they look at it in a completely different way. So I'm like, by all means, if that way is going to work for you, and they put a needle, let's say, in your big toe, and that helps, great, do that. Like, if that's
yeah. And
going to
you know what?
work,
That, their reasoning for doing that was different than what our reason would be. But say you put it into the toe, you affect the flexor hallucis. Okay, now your big toe is moving better. All of a sudden, your ankle joint, you're doing better toe off on your gait pattern.
yeah,
Okay, less stress on your tibialis posterior. Okay, now you're getting less internal rotation, things like that. There might be an anatomical reason.
right,
Does it matter why that needle was put there? I don't think so.
yeah,
It worked, and sometimes you don't need to boil it down to why it worked, but there probably is a reason.
Yeah. Why it worked, a lot of people have issues with that. So I'll see patients where I'll see them and then I'll be like, hey, listen, I think it's a disc. This is what I think's happening. We need to relieve some pressure off that disc. We need to do some, maybe let's try Mackenzie's. Let's see how that goes. Believing it's more flexion extension based. And so I'll try that, but then they'll be like, but why? Why do you think it's a disc? Have you done any imaging on it? How come you're not ordering an MRI to confirm it? But sometimes it's just like everything can be kind of perceived or understood or diagnosed without actual, imaging. Like you don't really need imaging to dive into that. Sometimes it's better just to treat it like a black box and just be like, this is what I think is happening. 90% of 90% of the diagnosis comes from the history. So let's go with this.
Towards disc.
Yeah, let's just go towards disc. Let's see what happens. If it doesn't work, once again, a trial of care. If it doesn't work, then we look into, okay, maybe let's try some other thing, some other type of treatment. Maybe it might mean including adjustments or kinesiology tape or something else. Maybe trying acupuncture, trying another form of therapy. And then I almost treat MRIs like pre-surgical. I'm like, hey, listen, we've tried everything conservative under the sun.
Yeah.
Nothing has worked. Exercise hasn't worked. Manual therapy hasn't worked. Adjustments haven't worked. Taping, acupuncture, whatever. We've tried all that. None of that has worked. Right. Now you're almost pre-surgical. Like I've tried everything. Let's book you in for a surgical consult. But before we do that, let's try to order an MRI because the surgeon will probably want an MRI to some extent. And then after that point, it's going to be invasive. Like it's either going to be medication, injections, or surgery. So it's like out of my hands anyways. But at least I tried everything. But they get so frustrated that like the image that I don't have imaging. Like how do you deal with that?
Well, I get that a lot. So, I mean, and there's obviously different ways that people practice. So, especially if you've had someone come into you from another office that's different than you are, and they, my chiropractor, they told me it was this. They got X-rays, and blah blah blah. That's great. I appreciate that. Come in. Yeah, I'll take a look. It's awesome. But we're gonna start fresh here. And you know what? An X-ray or an MRI is a picture in time. It doesn't show movement. It tells me what might be there, but it also doesn't tell me if that's what's actually causing it. Like you could have a disc derangement of some sort, but do the symptoms line up to it? Maybe not. So that's kind of irrelevant in your pain right now. If you just look at that MRI and you don't know the patient, you haven't seen the patient or talked to them, you might automatically think, okay, that disc is abnormal. It's likely causing pain. Let's fix that.
Right.
But if you saw the patient and you didn't have an MRI, they might present completely differently.
Yep, and we know that through the research. That's what the research says.
Come in that their imaging looks horrible. It looks like, based on this, I would think this person can't walk. They're in pain. They're miserable, right? But you walk fine, you're happy, and your pain has nothing to do with where these structures are. Like, there's nothing related to what it's showing. So I think people do put a lot of weight on imaging. I think it's extremely important in a lot of cases.
Yeah.
But you can also gather a lot of information and diagnoses pre-imaging. And sometimes imaging can plant that seed in the patient's head, and regardless of what you tell them, and you say your symptoms don't match, they'll still go back. Well, this is what the MRI showed. This is
I think the visualization is what they're chasing. They can see, a curvature. They can see that the disc space is reduced, and based off of that, they're making an assumption. But it's like what they don't realize is that there's a lot more to it. And I think movement questions are key, especially in taking the history. You're like, what hurts? What positions or movements hurt? And what positions or movements feel better? And then that gives us a better idea as to what's going to help them, or what we think is happening under their skin, deep within their body, and try to figure it out that way.
Yeah, absolutely.
But they weigh it too heavily. Yeah, it makes sense. Okay, let's move on to the speed round.
Okay.